The next issue we wanted to talk about was medication issues. When I see an older patient with a hip pain, they're often on 8 or 10 medicines for unrelated conditions from 3 or 4 different doctors. But I'm held accountable for what happens when they're on my service. Another subspecialist told me it's frustrating. I'll prescribe medicines that I know will be helpful. Patient doesn't get them filled, or they stop taking them, or one of the other doctors they see takes it off the list. So as you can see, there's a lot of this going on, and up until recently, we never saw each other's medical records, and maybe weren't even aware of the discrepancies in what one doctor was prescribing. But now we can see all that, and we can realize that there are some real problems there, and we're just not set up to deal with that. So how can we respond to the subspecialist around this? Well, I think one of the most important things we can do is to get them connected to a clinical pharmacist. We just had an experience working with one of the psych hospitals in the region, where they're across the street from the regular hospital, but they had never had a clinical pharmacist on their wards. So just by connecting them, we now have a meds to beds program. We now have all sorts of other kinds of benefits, from the clinical pharmacist to doing rounds every day on the wards. So these people can be tremendously helpful, and they can make sure that real medication reconciliation does happen. In the outpatient setting, certainly having relationships with the primary care team when there seem to be conflicts about treatment regimens, instead of just warring through the EHR, a phone call or a meeting could be helpful in those situations. And again, you can use your care managers to talk to one another. And there are many retail pharmacists now who are willing to come out from behind the counter and do medication reconciliation with patients that could easily prevent unnecessary hospital care.